The subcommittee hearing will come to order. Today, the Health Subcommittee is meeting to hear about the Medicare Payment Advisory Commission's, or MedPAC's, June 2010 report on aligning incentives in Medicare. And let me begin by welcoming to the subcommittee Mr. Glenn Hackbarth, who currently serves as chairman of the commission and will be our only witness testifying before us today. So thank you for being here. I'm going to recognize myself for an opening statement initially. Every year, MedPAC is required under the law to issue 2 reports and advise Congress on issues affecting the Medicare program. I believe that the report we're discussing today holds particular significance because it's the first report issued by MedPAC since passage of the new health reform law. I think that is significant for a couple of reasons. First, the contents of this report demonstrate the need for some of the policies that were included in the new health reform law, including provisions that will improve the quality of care and strengthen the financial sustainability of Medicare. Take, for example, the first chapter of this year's report, which examines opportunities to enhance Medicare's ability to innovate. The report notes that the Secretary of Health and Human Services and the Administrator of the Centers for Medicare and Medicaid Services need greater flexibility to implement innovative payment, coverage, and delivery system reform policies in Medicare. As the Commission's report currently points out, as part of the Patient Protection and Affordable Care Act, Congress authorized the creation of a Center for Medicare and Medicaid Innovation within CMS. In addition, the new health reform law improves the flexibility that HHS and CMS have over Medicare by, and I'll give you some examples first, simplifying the demonstration, approval, and implementation process within CMS. Second, authorizing new funding for CMS to carry out important new demonstrations that will improve quality and lower health care costs. And third, creating a new process by which the Secretary of HHS can expand successful demonstrations without further congressional approval. Now, on that last note, while I agree the agency needs further flexibility to test new models and improve Medicare's health delivery system, I'm not in favor of giving carte blanche to the Secretary of HHS or the CMS Administrator. I believe that this committee and the members who serve on it carry out an important oversight and regulatory role, and I'm not eager to hand over all of our responsibilities to effectively manage this program to our friends at HHS. This year's report also talks about the need for better care coordination, especially among some of Medicare's most vulnerable patients, such as those that are dually eligible for both Medicare and Medicaid. The new health reform law also makes inroads in this area with the inclusion of new team-based and integrated care models for delivery healthcare services, such as accountable care organizations, medical homes, and bundled payments. It's clear to me that there's a lot of correlation between some of the recommendations made in this month's report and some of the initiatives that were included in the new health reform. But the Commission's new report also seeks to examine other opportunities for the Congress to improve the Medicare program. For example, the Commission takes a fresh look at the way Medicare funds graduate medical education in the country and makes recommendations on how to improve it. The Commission also looks at the growth of payments for in-office ancillary services, an issue that they've examined in the past. However, this year, instead of simply looking at how physicians' behavior is adding to the growth in these services, MedPAC also looks at the role beneficiaries play in driving up the volume of these services. I'm also anxious to hear about MedPAC's research and recommendations in these areas, but I also think that we need to proceed carefully. I have concerns and questions that need to be answered. For example, what would be the impact of your recommendations on GME with regard to teaching hospitals that rely heavily on these funds? Can hospitals that operate on very slim margins or in the red, like those in my state, will they continue to operate and provide the same level of services if they begin to lose GME funding? I also worry about imposing new cost-sharing requirements on beneficiaries as part of a new value-based insurance design, and the impact that might have on beneficiaries who might forego important treatment rather than pay a cost-sharing requirement. Also, in terms of value-based insurance designs, who decides what services are high value, what services are low value? These are important questions, and I look forward to hearing the answers at today's hearing. And finally, let me note that it would be inappropriate for the subcommittee to hold a hearing on Medicare payments and incentives without addressing the elephant in the room, which is the annual payment cut that doctors face. This year, as everyone knows, physicians participating in Medicare face a 21% cut. We've been able to prevent this cut from taking place thus far through a series of temporary delays. As you know, before the Memorial Day recess, the House passed a bill that would provide another temporary reprieve to physicians by delaying that cut from being imposed and replacing it with a modest increase through the end of 2011. Our colleagues in the Senate have advocated for a shorter-term pared-down package, nothing new, and we have been unable to find agreement up to this point. So we all realize the need for swift action. I don't have to tell you how many doctors come to my office, not so much here, but in New Jersey, complaining about the fact that they'd like to see a permanent fix, which obviously we've also voted on in the House, but we can't get passed in the Senate. So the Democrats and Republicans in both houses, as well as the physician community, need to work together to develop a permanent fix. We simply can't continue to kick the can down the road. I know I feel like I'm talking to the choir here because, you know, the members on this committee are not, for the most part, the bad guys on this one, but we have to mention it. So I want to recognize Mr. Shimkus.
Thank you, Mr. Chairman, and thank you for joining us. We all know that MedPAC is critical in advising us as we make legislative decisions to alter Medicare. We must find ways to reform on entitlements, including Medicare, to make them sustainable into the future. By 2020, almost 93 cents of every dollar of federal revenue will be spent on entitlements and net interest costs. By 2030, net interest payments on our federal debt will exceed 8%. This will make interest payments the largest single expenditure in the federal government and leave little room for all other spending. Change is necessary, but we should do what we can to avoid unintended consequences. MedPAC's June report raises concerns over rapid growth in ancillary services in physician offices. The report provides options to address growth in diagnostic imaging, radiation therapy, and physical therapy in physician offices. These are very different services, and an option appropriate for one of these services may not be for the others. We must use caution to not paint all ancillary services with the same broad brush. I am pleased the report covers the graduate medical education system. I hear from hospitals already in my district all the time over the unmet need of residency slots, and from the physician community on wanting more flexibility to train in settings outside the hospital. While I believe we must examine these GME issues, I am hesitant in removing $3.5 billion in funds hospitals rely on through their indirect medical education payments. I look forward to hearing more from MedPAC on working to strike a balance. As we seek MedPAC's guidance for Medicare, what does the health reform law do to sustain quality and access to care? As Chairman Pallone mentioned, the new law does nothing to address the 21% cut. He didn't mention that. He did address the concern about the cut to our doctors, now taking as a turn away from Medicare patients. In Illinois, 18% of all doctors are now restricting the number of Medicare patients in their practice. A story just broke yesterday. The law does, however, cut $500 billion from Medicare. Billions of dollars in cuts that would not enhance the ability of the government to pay for future Medicare benefits, according to CBO. Medicare D premiums will rise for all of the nearly 28 million participants. Again, this is from the nonpartisan CBO. Half of seniors enrolled in Medicare Advantage will lose their plans, and all seniors will have access to care in hospitals jeopardized with the law causing 15% of Part A hospitals become unprofitable within 10 years. A figure CMS's own actuaries say may lead some to terminate their participation in Medicare entirely, and this is only some of the effects on Medicare. Yesterday, the President remarked the new law will cut cost, make coverage more affordable. Last month, the CBO said the price tag is actually higher with an additional $115 billion in discretionary spending. And before then, CMS and the country will spend $310 billion more under the new law than we would have without it. As for affordability, CBO concluded self-employed small business workers, early retirees, and millions of other Americans who buy their own health insurance plans will pay on average $2,100 a year more. Again, yesterday we heard the President using the bully pulpit to tout the benefit to small businesses and the relief it would provide. But only 12% of businesses would see any relief at all, with even fewer eligible for the full tax credit. And to get that full tax credit, you can only have 10 or few employees making an average of $25,000 or less. The message to employers is clear. Don't hire and don't pay your current employees more. Finally, the majority continues to claim the high-risk pools provide immediate access to insurance to those uninsured because of pre-existing conditions. Now the high-risk pools are set to go online in July, and CBO tells us the number of people who may be eligible for this program is in the millions, yet enrollment will be around 200,000 people. And in Illinois, they will miss the deadline altogether and might start enrolling people in its pool mid to late August. For those in current high-risk pools in Illinois, they will pay higher premiums than those in the federal one. Illinois will receive $196 million to set up the pool that would cover only about 5,000 people between now and 2014. 5,000 people among its 2.5 million people in Illinois living with chronic conditions. I warned as recently as last week that the $5 billion would not be enough to fill this need, and now those warnings are proving true. The Illinois Insurance Commissioner said this week demand will almost certainly outstrip funding, and eligibility will probably be limited at first to people with a fairly narrow list of health conditions. So the high-risk pool is going to pick and choose. Not enough money, not meeting deadlines, and limiting the enrollees. Can we honestly say to Americans we are providing immediate access to affordable insurance for those with pre-existing conditions? If all these experts' analysis are true, shouldn't the committee hold hearings and take immediate action to address these problems? And if the claims are inaccurate, should we not clear the air? Republicans have asked for multiple hearings on the law and wait as deadline passes and promises to the American people are broken. And I yield back my time. Thank you, Mr. Chairman.
Thank you, Mr. Shimkus. The gentlewoman from Florida, Ms. Castor.
Mr. Chairman, for convening this hearing today. Welcome, Mr. Hackworth. This hearing is vital to all of our parents and grandparents that rely on Medicare for their health care. It's also vital to all of our families, as Medicare often sets the course for health care and health care delivery in America. So I'm very encouraged by MedPAC's recommendations to continue to focus on the quality of care and increasing value of our health care delivery system. I'm also encouraged by MedPAC's concept of creating Medicare payment incentives as we improve quality. Chairman Hackbarth, you have mentioned in your testimony patients do not always receive the recommended care for their health conditions. And they may receive care that is not clinically appropriate, and this must continue to be our focus. I've introduced legislation, the Eliminating Disparities in Breast Cancer Treatment Act, which speaks to some of the same strategies that is tying Medicare payments to quality care and rewarding efficiency and quality. And this will help to see that patients receive higher quality care based upon the recommended quality standards. And I'm interested in hearing from MedPAC on incentives in the Medicare fee-for-services payment system that may be at the root of our primary care shortages. If indeed the current payment system, which according to MedPAC rewards volume in favor of certain specialties, which may be more lucrative simply because of higher volume of individual procedures offered as compared to primary care, this is something we've got to continue to address beyond what we've already done in the health reform area. I'm also very concerned where we stand on graduate medical education. And you see, where we start puts my home state of Florida. We are in such a deep hole. I'm very concerned if we go full speed ahead on reform, Florida is going to continue to be left behind. You see, we're the fourth largest state in the country, a very dynamic state with strong medical schools, and we're 44th in the number of medical residencies. So that means that the folks I represent may not be getting the care that they need because oftentimes those doctors in training, they'll go and take their residency in another state and they don't come back. So I want to get into that discussion with you today. We also have an aging physician population, 1/4 are over the age of 65 in my state, so you can see we have a looming crisis on our hands. So I look forward to hearing from you on all of these issues as we continue to ensure that health reform works for all American families. Thank you.
Thank you, Ms. Castor. Our ranking member, Mr. Barton.
Thank you, Mr. Chairman. I want to thank Mr. Hackbarth for testifying before the committee today. MedPAC provides a valuable service to Congress. We always appreciate the candid and detailed analysis of the Medicare program that they give. I'm pleased to see that MedPAC has addressed graduate medical education and has recommended ways to encourage teaching programs that emphasize non-hospital care and care coordination, focus on the delivery of efficient, quality care. Just recently, we learned that a number of doctors are now refusing to take new Medicare patients because government reimbursement rates are so low. It's simply too costly for those doctors to take new patients. We're hearing this at a time when baby boomers are increasingly entering the program. Meanwhile, the majority has failed to fix Medicare's Sustainable Growth Rate, or SGR, resulting in a 21% cut in payments to doctors. Thus, it's imperative that we listen to MedPAC's advice on how to produce professionals with the skills to practice in the Medicare system now more than ever. The recommendations in this report only scratch the surface of what must be done, not only in Medicare, but our entire healthcare system. We are only a few months into the implementation of the new healthcare law, pushed through recently on a purely partisan vote. We already see strong evidence that the new law is not solving our healthcare problems. Rather, it's increasing cost and crippling healthcare. I think it's a fair observation that the evidence is mounting on how and when President Obama's new law will make healthcare worse for many Americans. Internal documents requested by the majority show that companies across the country are engaged in a serious discussion about dropping health care coverage for their employees. It looks like the increased cost and disincentives of the law are simply more than many employers can afford in the middle of a recession. Finally, we also understand something all too well now that President Obama would not admit when his health care bill was up for debate. It will strangle Medicare. The chief actuary of Medicare now reports that the health care law just passed cuts approximately $575 billion from Medicare over the next 10 years. Mr. Chairman, I think it's a good thing that you've called this hearing. I look forward to our witness and then asking questions. Thank you.
Thank you, Mr. Barton. Next is Chairman Emeritus, Mr. Dingell.
Thank you, Mr. Chairman. I commend you for the hearing. Established in 1997, the Medicare Payment Advisory Commission has provided invaluable advice to the Congress concerning the Medicare program. Through their biannual reports, they have consistently advocated for a more efficient Medicare program that ensures beneficiary access to high-quality care, pays health care providers and health plans fairly, and spends federal tax dollars properly. It's important to note that many of the recommendations included in the recent MedPAC reports, including many recommendations in the current report, were included in the landmark healthcare reform legislation passed by the Congress and signed by President Obama earlier this year. These regulations include providing a payment bonus to physicians who practice primary care, reducing payments to hospitals with high preventable readmission rates, and testing the feasibility of a bundled payment for an episode of care. This is a testimony to the efforts of the sponsors of that bill and the administration to do all we can to make the Medicare program and indirectly private insurance a smarter, more efficient deliverer and payer for high-quality health care. In addition to the work accomplished by the new health reform law, MedPAC has provided a number of additional recommendations to consider on ways to improve the ability of the Center for Medicare and Medicaid Services to innovate, ensure the healthcare workforce is adequately trained, and to assist Medicare beneficiaries in making better decisions about the course of their healthcare treatment. I look forward to Mr. Hackbarth's testimony. I look forward to spending more time exploring the goals and the impact, both direct and indirect, of the recommendations included in the June report, and I hope that this subcommittee and committee will do so alike. Finally, I'm very interested in exploring MedPAC's future relationship with the new Independent Payment Advisory Board created by the new health reform law. This legislation envisions some interaction between the two. It is my hope that that will occur, but that it will occur in a beneficial way. However, we must think very carefully about how the two entities coexist beyond the specifics of the legislation, and this committee must again direct its attention to that. So thank you very much, Mr. Chairman. I yield back 2 minutes and 10 seconds.
Thank you, Chairman Dingell. Next, we'll go to the gentleman from Kentucky, Mr. Whitfield.
Thank you, Mr. Chairman. I'm going to waive my opening statement.
Okay, and next is the gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding this hearing on MedPAC's latest report to Congress, and our thanks to Mr. Hackbarth and the members of MedPAC for your work on the report and for being here to testify today. I just can't help but say something before I make the rest of my remarks. My friend from Illinois keeps hacking away at the National Health Care Plan, which we passed, and talking about the cuts to Medicare. I think that we need to get the record set straight. There are, or were, insurers in the country that were receiving up to 135% more in payments than others. So while it's called Medicare Advantage for some of my constituents, it was clearly Medicare Disadvantage for other constituents. Now all of those monies that went into the overpayments for those insurers are being plowed back into Medicare. So I think we need to keep, I mean, we all have our opinions about
Would
things.
the gentlelady yield just 1
no,
second?
I'm not going to yield. But
Okay.
no, it's my time. And but to just try and shape, to pretend that something is a fact when it's not, it's really unworthy.
Is the gentlelady questioning my...
No. Anyway, getting back to our hearing today, I'm very pleased that a significant portion of your report, Mr. Hackbarth, focuses on the signals that Medicare sends to medical students through the GME financing, the graduate medical financing. From the point of view of hospitals, though, not all residencies are created equal. And I think that this is something that, and Medicare largely funds them as if they were. I think that we've had a long struggle with the problem that medical students are choosing to subspecialize rather than choose family care or primary care, which is one of the things that we, I think, addressed in the health care legislation. And Medicare supportive residency slots, I think, should aim to create the correct proportion of specialists and not just the current proportions. And I think that this is a discussion that we have to continue to have, especially in view of the millions of Americans soon to be insured. So I look forward to your testimony. I thank you for your work, and I thank the chairman for calling this important hearing.
Thank you, Ms. Eshoo. Next is gentleman from Georgia, Mr. Gingrey. Oh, I'm sorry. Yeah, no, that's correct. Yes, Mr. Gingrey.
Thank you, Mr. Chairman. Mr. Chairman, our Medicare program is facing a dark future, made worse by President Obama's health reform law that this Congress passed back in March. As Chairman Hackbarth will outline in his testimony, the Medicare Hospital Trust Fund's expenses exceeded its income in 2008, meaning that its current trajectory is unsustainable. This path, if left unaddressed, could rob future generations of a quality Medicare benefit. Over the last 18 months, Democrats in Congress cut $500 billion from the Medicare program in order to help pay for President Obama's health care bill. And by the way, the gentlelady from California, Ms. Eshoo, says that $500 billion cut of Medicare, much of which comes from Medicare Advantage, was piled right back into the Medicare program. Nothing could be further from the truth. In fact, I had an amendment when the bill was marked up in the House, H.R. 3200, that would have affected that, but it was rejected by the Democratic majority. The majority said the $500 billion came from ending waste, fraud, and abuse. CMS actuary Robert Foster countered that argument by stating that the cuts would result in 9.4 million seniors losing their current Medicare benefits primarily in the Medicare Advantage program and paying higher out-of-pocket costs for their health care. Make no mistake, seniors' costs will go up because of Obamacare. Congress could have used that money to cap out-of-pocket expenses or to help offset deductibles under Medicare in order to truly lower health care costs for low-income seniors with chronic illnesses. But the Democratic majority could have put those funds back into the Medicare Trust Fund so that seniors don't wake up one day soon and find their health care program bankrupt. Speaker Pelosi could have taken that $500 billion and permanently addressed the physician payment crisis under Medicare that is currently threatening our seniors' access to quality care. If cutting $500 billion from a Medicare program that is going broke does not worry seniors enough, the President is now pushing Dr. Donald Berwick for the post of CMS Administrator. He is a self-described proponent of rationing health care from sick Americans. A New York Times piece that ran just yesterday quotes Dr. Berwick as, quote, in love with the British healthcare system, unquote, and stating that, quote, the national health system is not just a national treasure, it's a global treasure, unquote. This is the same British system that routinely makes coverage decisions based on cost and life expectancy. This is the same British system that denied coverage for the breast cancer drug Herceptin because it was not deemed cost-effective. It took a protest march by thousands of women in the streets of London to change that decision. Simply put, our seniors' health care program cannot afford Dr. Berwick. Mr. Hackbarth, it's with these thoughts in mind I look forward to your testimony today. You and your staff have served this Congress well, offering technical advice and insight into ways that we might restructure our Medicare program so that seniors' health care and needs and taxpayer interests are indeed safeguarded. Particularly, I'm interested in your thoughts on how we might overhaul our current system of reimbursing physicians under Medicare, the sustainable growth rate, and how properly aligning incentives in the program might encourage a greater efficiency and collaboration. With that, Mr. Chairman, I'll yield back. I thank you for your patience.
Thank you. Next is our chairman, Mr. Waxman.
Thank you, Chairman Pallone, for calling this hearing. We're going to hear from representative from MedPAC, which is an organization set up to advise the Congress about the Medicare program. And they've done an excellent job over the years. In fact, many of their recommendations were incorporated into the recently passed comprehensive health insurance bill. That bill is going to extend health insurance coverage to 30 million Americans. It's going to hold down costs, and it's going to benefit the Medicare beneficiaries. You wouldn't believe it by the propaganda line we've gotten from the Republican side of the aisle. They were against working on a bipartisan basis with us. They complained about the bill before it was enacted. They've complained about the bill since it's been enacted, and it's not even implemented. But some things are going to be implemented. For example, we heard about the high-risk pools being a failure. The high-risk pools are a temporary way to cover people with pre-existing medical conditions who cannot buy insurance at all. Well, this will give them a chance to buy insurance until the insurance system is implemented where they can no longer be discriminated against, something the Republicans would not support. They've complained that this is going to do a disservice to Medicare. Well, the truth of the matter is that the Medicare Trust Fund is going to be extended for many, many years. The Medicare Trust Fund will be extended for 12 years to 2029. They've talked about some of the cuts in Medicare, but those cuts are wasteful expenditures to insurance companies that are telling Medicare beneficiaries that they should have more money for their overhead. We said no, the money ought to go for health care services, and this was one of the recommendations of MedPAC, not to have these so-called Medicare Advantage plans get overly compensated. But not only are we saving money in the expenditure of Medicare, we are also going to be closing the donut hole so seniors will not find themselves going broke, having to pay 100% of the full cost for their prescription drugs, something the Republicans provided for when they adopted their original Part D Medicare legislation. We'll close the donut hole. We'll provide preventive services without costs to the seniors. They won't have to come in with co-payments. We extended the life of the Medicare Trust Fund. You would think we ended Medicare. You would have thought that we're putting the American people on the British system. To hear my colleague from Georgia a minute ago talk about the result of the health care bill. The hearing we're having today is not the first hearing we've had on the whole health care system. The Congress of the United States, in fact the House, held 79 bipartisan hearings and markups on health insurance reform over the past 2 years. We had hearings. We got full input from everybody, people who had different points of view, those who were in favor and those who were against. And out of those hearings, we worked on legislation, but we had to do it on a partisan basis because, like every bill that we have considered in the last year and a half, the Republicans have decided to vote no. They voted no on the stimulus bill. They voted no on the energy bill. They voted no on the health bill. They voted no on the financial reform bill. They are the party of no. And now, when we're trying to learn more about what we need to do to keep Medicare the program it is as a way to provide health care services for our seniors and our disabled people, they want to complain, not talk about how we can work together. MedPAC has given us a report, and that's the reason for this hearing. Their report is always useful. They've suggested that there are ways we should deal with graduate medical education to try to get physician services based more on quality and not on quantity. They're recommending what we should do with people who are both Medicare and Medicaid, the dually eligibles. They've given us a lot of good substantive things to look at and to work on. And I'm pleased with what they've done in the past. That's been part of the health care bill that's now law. And I'm looking forward to the testimony about further things that we need to do to strengthen the Medicare program. But let no one be fooled. What we're seeing is a lot of propaganda from our Republican colleagues. It's the same thing we've heard at every hearing over and over again, that you're going to have ration care, you're not going to have care, that everybody's going to drop the care. And meanwhile, they wouldn't even eliminate the barrier for people to buy insurance because of pre-existing medical conditions. I'm glad the health care bill passed. People will welcome it to effect. You're back.
Thank you. Is the gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. Mr. Hackbarth, we are pleased that you're here. As you can see, we are going to have a very robust discussion today. I know you're looking forward to it, and I think we all agree that there are some improvements that are needed in the current delivery system. But I'll have to tell you that there's a lot of concern out there that Obamacare is going to be detrimental to Medicare, and that it has the potential not only to cripple the nation's health going forward, but also to cripple and compromise those health care delivery systems. And most recently, we've had concerns expressed from physicians, and I know you're hearing this too, about being able to meet the cost of their practices while they are facing reductions, even to the point of phasing out of programs like Medicare Advantage. And yesterday there was a USA Today article, and I'm sure you probably saw this. There was a quote in there: the number of doctors refusing new Medicare patients because of low government payment rates is setting a new high. And this is of concern to us. The AMA has even reported that 31% of primary care physicians are no longer accepting new Medicare patients. We're hearing quite a bit about this, and what we hear is that this 21% reduction in the SGR is forcing more doctors to make those reductions and dropping patients. And seniors are very concerned about this. Now, I think that they are speaking up and expressing concerns, and one of the reasons we want to hear from you is because, you know, my colleague across the aisle just said we are the party of no. I would change that to for him. We are the party of KNOW, no. And what we have worked diligently to do is to make certain that seniors have the information in front of them, whether it is about their Medicare Advantage and their concerns of that program being phased out, or whether it is about the current Medicare coverage that they have. And they continue to come to us and say, you know, we thought we were going to be able to keep the benefits and the programs that we had, but we don't see how this is going to work. And what we're hearing from insurers is that changes are coming toward us. And when you see numbers like $136 billion being cut out of Medicare Advantage over the next 10 years, this is of concern. I will also highlight that we have to remember that our seniors, today's seniors, have prepaid their access to Medicare. And we need to be mindful of that. We need to be respectful of that. And we welcome your insight and look forward to the hearing. I yield back.
Thank you, Ms. Blackburn. Next, for an opening statement is the gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and thank you and Ranking Member Shimkus for holding this hearing, and thank you, Dr. Harkbath, for joining us this afternoon to report on the Commission's June 2010 report to Congress. The Medicare program has been in many ways an indispensable asset to the American elderly and disabled, and I welcome every opportunity to review and discuss aspects of the program that can be improved to increase the efficiency and quality of health care given to these populations. Approximately 20% of the enrollees served through Medicare are racial and ethnic minorities, and roughly half of all beneficiaries are within 200% of the federal poverty line. This is significant because these are the very beneficiaries who are extremely vulnerable, who suffer most detrimentally from health care inequities within the current health care system. And although Medicare provides health care access to millions of Americans who otherwise would go without coverage, the fact remains that prior to enrollment in Medicare, most were either uninsured or grossly underinsured, two scenarios that we know have deleterious health impacts. This means also that often by the time they enroll in Medicare, many of the health issues that might have been addressed relatively easy with access to care have now been compounded and exacerbated by a lack of care or poor care when it was available. Because of this, it was especially interesting to me to read the recommendations of the Commission, particularly as it pertained to focusing more on a payment method that encourages quality over quantity service and promoting more participation from both patient and provider in the decision-making process and in attracting more racially and ethnically, geographically and socioeconomically diverse healthcare workforce. I'm interested also in hearing more about how MedPAC suggests addressing the numerous health disparities that have been documented within the nation's Medicare population. And so again, I thank you for today's hearing, and I look forward to a very informative and thought-provoking discussion. Thank you, Mr. Chair. I yield back.
Thank you, Ms. Christensen. Next, for an opening statement, the gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman, and a couple of reasons why today's hearing is notable. And once again, we have a chance to hear from our good friend, Mr. Hackbarth, who's no stranger to this committee. Time for us to dig down deep and take a look at whether Medicare does a good job of shepherding the enormous resources available to the program to provide health coverage for millions of over Americans. That's the larger and the grander goal, but today is also notable because doctors across the country who participate in the Medicare system are receiving 21% less for the services they performed last month for taking care of some of our nation's sickest and most needy patients. Congress has broken the contract that we have with the nation's seniors and the nation's physicians in allowing this dramatic cut to take place. Let me point out, I have voted for some very bad policy in the past, very bad policy that had at its base stopping those cuts from occurring. Unfortunately, we have not had, in all the hearings that were referenced by Chairman Waxman, we have not had, since 2006, a hearing on the sustainable growth rate formula, and I think it's time we do that. I have a bill 3693. I'd like to see that get a full and fair hearing. Since this committee will not hold a hearing next month, I will be holding a forum by myself to talk about this very issue. And then what's worse is we have the Speaker, astonishing in her cruelty, holding up a bill. Okay, the bill's delinquent, maybe criminally so, It's insufficient, perhaps scandalously so, but still it's a reprieve for the nation's seniors and doctors, but the Speaker won't let it come to the floor because it doesn't comport with everything that she wants. I voted for very bad policy in the past just to prevent these problems from happening to our seniors and doctors. The Speaker should do the same thing. Very few members in Congress outside the physician members have any appreciation for what this delay and our inaction does to physician practices. When you have a small physician practice, even with as small a population as 15% Medicare, and you don't get paid for 3 weeks, that's a big deal. This decision will lead businesses to closing and patients losing their doctor. You know, we've got price controls in this country. Most of us don't admit that in health care, but we do. Every private insurance company in the country pegs to what we do in Medicare, and that's why it is so critically important that we get off our duff and do the right thing. We talk about the fact that people aren't going into the specialties that we want them to go into. We've got administrative pricing. We're driving people into the specialties that we now decry and keeping them out of the specialties we wish they would go into, but we're doing it by our administrative pricing. What about quality over quantity? When the only lever you pull is to ratchet down reimbursement rates, the only lever the doctor has to pull is to increase the number of hours they work or work a little bit harder or spend a little bit less time with each patient. The only way they can pay their overhead, and let me remind members of this committee that doctors who see patients in the Medicare program have not had any increase in their reimbursement since the year 2000. Now, I know we need a long-term strategy, and I've not always agreed with MedPAC's findings on the sheer amount of money and layer upon layer of bureaucracy that defines our current program. But that in and of itself calls out for a dramatic rethinking of the program. And as a committee, we do need to have a bipartisan dialogue. And unfortunately, Mr. Waxman has left, but I would remind him that I met with him early in 2009 to talk about, was there a possibility to work in a bipartisan fashion on this health care bill? I met with the transition team in November of 2008 to ask that very same question. I got no response as an answer. What did we get? We got a bill thrown over the transom on July 15th, and then we were brought to committee and told to mark it up.
Dr.
I had
Burgess,
50 amendments on that
you're
table.
a minute
I had my
over.
own table for amendments, and yet you say that the Republicans refuse to participate.
All right.
Where do you get this stuff? Do you just make it up?
You
out
got
of
it.
thin
You're
air?
over a minute, Dr. Burgess.
Well, I thank
Time
the chairman
has
for
run
his
out.
indulgence. I look forward to the hearing we're going to have on the SGR formula in short order. And, you know, we might also bring
All right,
Secretary
I'm gonna
of
have to
Human
rule you out of
Services in
order.
here and talk about
All
the
right,
administrative
come on.
function.
We're a
that they
minute
have.
over. I recognize Mr. Barrow.
I thank the chair. In the interest of time, I will waive an opening.
Okay. No, he's not yielding to you. Mr. Murphy of Pennsylvania.
Thank you, Mr. Chairman. It's good to have you here today, sir. I'm looking forward to a number of things. I'm looking forward to reading this book. I want to draw the committee's attention to something very important in the executive summary where you say Medicare oftentimes lacks the authority to deal with some prospective payment systems that would improve payment accuracy. Similarly, a change in law is also necessary for Medicare to implement policies that pay providers based on their quality. Medicare needs authority to make such changes in its current payment system. A while ago, when our new president took office, I had sent letters to his staff and other folks asking that Congress and the White House put together a blue ribbon panel to really review Medicare, which was designed in 1965, and design really from the bottom up, what would Medicare look like if we designed it now in 2010. Back when it was designed, as you know, some of the most advanced instruments hospitals had was an X-ray machine on wheels. We obviously have come a long way since then. And back then, it worked then with the limited things we had with medications and other treatments to pay a fee-for-service system. Now we have a substantial amount of research which says that quality is important, that care management is important, and those things can indeed save money. When we look at some of the things that happen now in Medicare, and it'll be interesting to hear your comments on this, it looks like many of the things require an act of Congress to change it. For example, we're still in a system that doesn't pay for someone in the nurse's office to coordinate care, even though that call to a diabetic is far cheaper than amputating the diabetic's legs. Stroke victims oftentimes can save money if you have a teleconference video, but that depends on where that hospital is, rural versus suburban, even if both are an equal distance in time by ambulance to the base hospital. Home infusion therapies are still limited, even though some of those save time and reduce the risk for infection. There's also things that have to do with how we even order wheelchairs and canes and deal with wage indexes that on the east side of Harrisburg in Pennsylvania they may get paid one way, the west side of Harrisburg in Pennsylvania may get paid a rate that is so much lower that doctors can't handle it. It is of concern, and I am pleased you're addressing this issue, that we cannot expect to prop up a system in Medicare that's struggling financially just with saying we're not going to pay. I believe the analogy we all understand, if someone comes to work on our home and we can have two estimates, one will say it's going to cost you this much to fix your roof, another guy will say I'm just going to charge you for each item I put up there and my hourly rate. We all know which one's going to cost a lot more. In each case, we're just looking to have the roof fixed. I hope that you can let us know, if not in today's hearing, in the future. It's extremely important to this committee and to me that we've got to revise this system of Medicare and make it up to date and give Medicare the flexibility to redesign itself as we have more breakthrough information and how we can best administer medicine. Putting on the backs of physicians just to say we're not going to pay you isn't going to work. Thank you so much. I yield back.
Thank you, Mr. Murphy. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. I'd like to waive opening statement, but also remind my Republican colleagues the health care bill that came out of the House had a permanent fix to the SGR, and lockstep, my Republican colleagues voted against it.
Will the gentleman yield?
I think the gentleman actually waived his, well, not waived, but didn't use his time, but somehow managed to get a statement in as well, so I don't know.
But
Anyway, let's move on to Ms. Schakowsky is recognized.
Thank you, Mr. Chairman, for this opportunity to discuss MedPAC's June 2010 report to Congress. I want to welcome Mr. Hackbarth for appearing before the committee and thank the staff at MedPAC for their work putting this together. Today's hearing is about improving the access to and effectiveness of Medicare. This Congress has implemented historic reforms to our broken health care system that takes gigantic steps forward to improve access and quality in health care for millions of Americans. We've extended the Medicare Trust Fund by an additional 12 years so that we can keep our promise to older Americans and disabled Americans. We've done what MedPAC has recommended that we do for years, which is to cut excess payments to private insurance companies for Medicare Advantage. We've eliminated cost sharing for preventive care in the Medicare program, and we are getting rid of the Republican-created donut hole. Moreover, health reform will reduce the national deficit by more than $100 billion in the first decade, $1 trillion in the decade after that. Your testimony discusses the highly unpredictable and highly variable cost of Medicare cost sharing. It's a point I fear many miss. According to AARP, people on Medicare spend an average of 30% of their income on out-of-pocket health care costs, including premiums for supplemental coverage. As co-chair of the Seniors Task Force, I often hear from constituents who pay hundreds of dollars a month for their Medicare. In 2010, it is $110.50 for most Part B premiums. The Kaiser Family Foundation reports that Part D premiums for prescription drug plans have jumped by 50% since 2006. And MedPAC's March report shows substantial increases in cost-sharing requirements for both brand name and generics in 2010. Finally, the NAIC statistics from a recent MedPAC report show that Medigap coverage costs policyholders pay $2,000 to $3,000 a year. Medigap policies are expensive, but they can protect against highly variable and unpredictable out-of-pocket expenses that you reference in your testimony. It is critical to note that Medigap policies aren't being used by people trying to shirk their health care responsibilities. They're being used by Americans who are a bit too rich for Medicaid, but who don't have the savings to pay for potentially devastating, uncertain medical expenses. I look forward to hearing your testimony today, and I yield back the balance of my time.
Thank you. Gentleman from Ohio, Mr. Space.
I'll waive my opening, Mr. Chairman.
Gentleman waves. I think that our opening statements, so we'll go now to our witness. First of all, let me welcome you again. I know you've been here before, and we always enjoy your insight. We've limited you to 5 minutes. I hope that's okay. If you need more, you can use it because you're the only witness. And if you proceed, thank you.
Thank you, Chairman Pallone, Ranking Member Shimkus, and other distinguished members of the subcommittee. I welcome this chance to talk about our June 2010 report to Congress. Let me begin by briefly reminding you about exactly who we are and how we do our work. MedPAC is a nonpartisan advisory group. We have 17 members. The process for appointing the members is run by GAO. For the commission that produced the June report had 6 physicians and 1 registered nurse on the commission. In addition, we had 5 commissioners that had executive level experience in running healthcare delivery organizations. Another 5 that had experience in running private health plans. And some commissioners have more than one of these credentials in their background. As chairman of MedPAC, I believe we can best serve the interests of Congress by, wherever possible, finding a consensus point of view among these diverse perspectives included on MedPAC. Usually we succeed in doing that. And just to illustrate that point, we've published 2 reports to Congress this year, in March and June. In total, there are 26 recommendations in those 2 reports, which represents roughly 400 individual votes by MedPAC commissioners. On those 400 individual votes, there were 0 no votes and 3 abstentions. So we're able to take a diverse group of people, diverse group of experiences in healthcare, and find common ground on how to improve the Medicare program. Our examination of any given issue usually spans multiple public meetings. We have 8 public meetings a year, and often we'll take up a complex topic, have discussions that explore the available information, ask our staff for additional analysis. Then we begin the discussion of options, and at each point in the process, we reach out to parties in the outside world who would be affected by the recommendations, who have expertise to bring to bear, and make sure we have the benefit of that information. So it can be a rather lengthy process to getting to final recommendations, but we believe that approach allows us to provide the best possible advice to the Congress. To provide a little bit of context for our discussion of the June report, I thought it would be useful for me to highlight some of the areas where MedPAC has made recommendations in the past and where there's a strong consensus among commissioners. First and perhaps foremost is that Medicare simply cannot go on as it is. The rate of growth in expenditures eventually will become unacceptable, and so we need to look in every way possible to find ways to slow the rate of growth in Medicare expenditures while preserving or hopefully even improving quality and access to care. To slow growth and increase value for Medicare beneficiaries, we'll have to act on a broad front. There is no single thing that we can do. Among the recommendations that we've made in the past are there needs to be consistent pressure applied to the unit prices for individual services, whether they be for physician services, hospital services, home health agency services, whatever the provider type. We need to look for ways to change the relative values of payment. Some of the members earlier mentioned primary care physicians versus subspecialty physicians. We need to look at opportunities to change those relative values in a way that signal what sort of care Medicare beneficiaries need more of and reward the provision of that care. Third, we need to look at reforming payment methods and using new payment methods, whether that's paying for quality or bundling services around hospital admissions, medical home. Those are several examples of what we consider to be payment reform. Fourth, there's a broad consensus within the Commission that we need a robust and value-focused Medicare Advantage program. Because private plans have the ability potentially to do things that traditional Medicare finds difficult. And finally, and most relevant for our June 2010 report, we think it's important for Medicare to begin the process of reforming its contributions to graduate medical education. And Mr. Chairman, I'd like to close with just a few comments about graduate medical education. I have a slide here that briefly summarizes our recommendations. In the interest of time, I'm not going to go through all the points in the slide. I'd like to focus instead on the context for our recommendations. MedPAC commissioners believe that our system of graduate medical education is, in many respects, the envy of the world. The system produces thousands of superbly skilled physicians each year. Physicians who are trained to apply the latest technology, latest technique to aid Medicare patients and other patients in need. On the other hand, there's a broad consensus within the Commission that the current GME system is not consistently producing the physicians we need to reorient our healthcare system toward a higher level of performance.
Mr. Hack, I can't read that. I must be getting old. Yeah. Is that in the book somewhere?
Yes, it is.
Okay.
And actually, I'll have somebody behind me find the page, and I'll tell you what the page is. Page 103 in the red book, the June 2010.
Thank you.
So another element of the consensus within MedPAC is that the GME system is not consistently producing the physicians we need to move towards a higher value healthcare system. And I would emphasize that's not just our judgment. That is the judgment of many other people that we consulted with, including many people within the graduate medical education system itself. Broadly speaking, we find two types of deficits in the GME system. One is in the mix of physicians being produced by the system. That includes the specialty mix, the number of primary care physicians relative to subspecialty physicians and the like, but it also includes the racial, ethnic, and geographic diversity of the physicians we train. The other area of deficit is in the content of training. While physicians are very well trained in advanced technology and techniques, we're concerned, as are many others, that there are important areas that are not as well focused upon, including evidence-based medicine, cost awareness, team-based care, care coordination, shared decision-making with patients, and the like. It's important to emphasize that, as MedPAC sees it, the GME system does not bear full responsibility for these deficits. For example, in the area of specialty mix, Medicare payment policies and those of private insurers strongly influence the choices that physicians in training make, and also influence the sort of training programs that teaching institutions decide to engage in. Moreover, I would add that the GME system deserves credit for its efforts to reform the content of training. For roughly the last decade, ACGME, the accrediting body for graduate medical education, has been engaged in what they refer to as an outcomes project, which is designed to refocus training on new skills that physicians need to produce high-value health care. We believe that that movement is largely in the right direction, but we think that the pace needs to be accelerated. And we propose to do that by making a portion of Medicare funding contingent on the development of and adherence to new standards of performance for graduate medical education. And we urge that all of the relevant voices be included in developing those standards, not just people involved in academic medicine, but also representatives of patients, purchasers, and high-performing delivery systems. Thank you, Mr. Chairman. Those are my opening remarks. I look forward to your questions.
Thank you. And we're going to have questions, obviously, and I'll start by with my questions. I want to focus on the GMEs. I'm concerned about the fact that you're apparently suggesting taking some of the existing funding and redirecting it based on these standards of performance, and I'm worried about placing further financial strain on safety net hospitals, which I represent some. Many of them have already called me about this proposal, and I also I'm not really sure. Now, again, I haven't read the report in all its detail, but what is the significance of this empirically justified amount? In other words, what you're saying is if it's above the empirically justified amount, then that's the money that would be redirected. What is that criteria, empirically justified amount?
Okay. Medicare pays roughly $9.5 billion for graduate medical education each year, and it basically is broken into three relatively equal parts. The first is what we refer to as the direct medical education payments. Those dollars pay for resident salaries, faculty salaries, direct expenses of that sort. The other two pieces are paid through the indirect medical education adjustment. Teaching hospitals receive a percentage add-on to each payment they get for a Medicare admission based on a formula that includes the resident-to-bed ratio. When Congress enacted that adjustment back in 1983, it asked for an analysis of how much costs increased in a hospital due to teaching activity, and that amount was calculated. Congress basically doubled that amount. So we refer to the actual increased cost in hospital care as the empirical amount, and then the additional doubling of it as the extra IME.
But you see, the problem that I have is, one could argue that all of this is very artificial and that we should have a totally different method of financing graduate medical education. And, I mean, we could have a series of hearings on that. Maybe we should. Mm-hmm. But the problem is the reality. I mean, the reality is that these hospitals are depending upon this money. It may be somewhat of an artificial formula, but at this time, if you're just going to say, okay, we're going to take some of the money away, I just think I'm concerned that this is not the right time to do that. I mean, we can argue about how this formula was set up, but right now at this time, given the recession, given, all the things that we face out there, why does the Commission feel that this is a wise step right now?
Yeah, well, I'd like to emphasize that we're not saying take the money away.
But isn't that affect what would be happening?
Well, what we're saying is establish accountability for the use of the funds. Let's make sure that for this.
But my point, Doctor, is that, we get to the point where the way we've gotten to this formula now, you can argue how we got there or not, but you have to be concerned, or at least I think I do, and I think many of my colleagues, about the consequences of it. And I'm just concerned that, I want you to be innovative and come up with new ideas. Many of your ideas we've incorporated in the healthcare reform. I'm not suggesting otherwise, but it just seems that right now, if the consequence of this is that money is taken away from some of these hospitals that are, that are in the red, have you taken that into account?
We have, and what we've proposed is that the new standards would take effect 3 years from now. So there would be a 3-year period to develop the standards that would guide the new payment policy, and to give the institutions an opportunity to prepare to adhere to those standards.
Okay, I think I'm going to stop because I wanted to ask one more question. I'm sure my other colleagues are going to delve into this GMB thing more. So let me just ask about the diagnostic tests. In your report, you explore the suggestion that reducing payment rates for diagnostic tests performed under the in-office ancillary exemption would help to slow growth for these services. But I wanted to ask you, beyond the 2006 and 2008 data you examined, to what extent did you take into account the cuts that have occurred in the recent past? For example, the impacts of the Deficit Reduction Act, the reductions in payments due to January 1st, 2010 changes in physician fee schedule. The concern I have is the rates for these services, particularly advanced imaging, have declined significantly in recent years. And you know, so again, I'm again hearing from them about how, you know, this is going to be a problem because of all the cuts they've already had.
Yeah. Well, what we've proposed is a series of very targeted reductions in payment for imaging. And we have taken into account the effect of those, and we think that the payments would continue to be adequate to assure reasonable access. What we have right now is very rapid growth in high-end imaging, and a lot of people investing in equipment, and then once it's in the office, using it at a high rate. And to us, that signals that the payments have been quite generous in the past. And what we need to do is bring the payments more in line with the cost of that care. And then we've recommended redirect those funds to other higher value uses for the Medicare program.
Okay, thank you. Mr. Shimkus.
Yeah, thank you, Mr. Chairman. And Mr. Hackbar, I apologize for you getting involved in the health care law food fight. But we only get the opportunity to openly discuss this, and I think it does call for a hearing. That's all we're saying. That's our point. If they're right, let's have a hearing. If we're right, let's have a hearing. And there are problems that in this law we know that need to be fixed. There are smaller ones, but so we just take the opportunity, the limited opportunity we have to address our concerns. And in response to the chairman, we did pass a bipartisan bill called Food Safety Bill. Passed out of here on a voice vote, I think, and passed on the floor. And we were involved in that. And when we are asked to work together, I think we could do so effectively. The health care bill creates a $1 trillion new cost. And I'm just going to end on this $500 billion. $500 billion wasn't all Medicare Advantage, as you know. $20 billion was revision to the Medicare Improvement Fund, which is to help doctors continue to take Medicare patients. $20 billion over 5 years. $156 billion came from ensuring Medicare sustainability. Revision in the market basket updates, which is payments to hospitals. $156 billion out of 5 years on this new law. Payment adjustments for home health. $40 billion. So I would caution my colleagues that there is $135 billion on the Medicare Advantage. That's something they did mention. But I would question to make sure we do a total of the entire $500 billion in cuts, because some of it's to hospitals, some of it's to individuals. And that's what this law did. I look at the trying to find the mission statement, and under the front cover says Medicare, you're supposed to help us on Medicare Advantage program, providers in the Medicare's traditional fee-for-service, and analyze care, quality of care, and other issues affecting Medicare. And you do, but I think for macro versus micro, I mean, you've gotten into a lot of the micro aspects of, and you've done it for a long time, and again, well respected and been around for a long time. We're worried about some of the macro issues too, and I know because of implementation takes time, it's tough to check the implementations of the new law, especially in this report, but I think that's an important aspect to look at, especially when you have, whether they like to admit or not, $500 billion of cuts, and it's not all coming from Medicare Advantage. It's coming from hospitals, it's coming from physicians, there's tax increases that are going to affect service. Having said that, are the people on the committee, now I was going through the bios, are there any economists on here?
Yes, sir.
And the physicians are for-profit and not-for-profit? The hospital administrators from both for-profit hospitals and not-for-profit hospitals?
Currently, not-for-profit.
Just not-for-profit.
Yeah.
No for-profit hospitals.
No for-profit hospitals, no.
Is there a reason? Do we know?
As I say, the GAO does the appointments. So we don't select our own members. And so I don't know the answer to that question. And I wouldn't expect that we would never have a for-profit.
Right. No.
We just currently...
No, it's a very impressive list. My point, I'm a market-based capitalist conservative. I believe in supply and demand. I believe in individual consumers given the ability to access information will drive prices. You'll get higher quality and lower costs. I'm concerned about third-party payers and institutions that, in essence, try to set fees when an individual consumer, given the information and the access, probably is a better system. The GME issue is just one sliver of what you're doing, but I understand it's a very important aspect to you. We have hospitals that have too many GME slots. We have places in this country with not enough slots. In the moving of, I want more slots. Is what I want. Is there in the calculation of the payments? Is the payment, say for a GMA slot in New York City, is it the payment the same as it would be in Springfield, Illinois, for a teaching hospital, or is there a cost of where the education is going? Is there a percentage ratio there?
Well, we've got, as I said to Chairman Pallone, we've got two different types of GME payments. We've got the direct payments for salaries and the like, and then we have the indirect add-on. The direct payments are set at a hospital-specific amount. So there was a base year based on the actual costs incurred for salaries and direct expenses in that year, and then that's been inflated by the CPI since. The indirect piece is a percentage add-on to whatever they get paid for a Medicare admission. So that does reflect different wage indices and different cost of care.
So, and I'll end on this, and I appreciate the Chairman's permission to just finish with the statement. We need more. In this environment, with doctors talking about leaving the profession, we need more doctors. We need more GME slots, and I believe in supply and demand. And the higher supply you have, the lower cost. More supply, you'll have lower cost. But we've got to get them out, and they've got to get trained in educational institutions.
Chairman Plum, could I just
please respond.
Make a brief comment about the number of slots? It may well be true that we need more slots, more physicians being trained. That's not an issue that we've looked specifically at, but there's certainly a lot of people who believe that. What we have said, though, is that before Medicare decides to fund more slots, we think we would do well to step back and do a careful assessment of what our long-term needs are likely to be. We shouldn't just extrapolate from the past, but look at the mix of physicians and other health professionals that we'll need for a more efficient system in the future, and then base our decisions about GME funding on that analysis.
Thank you.
Thank you. The gentlewoman from Florida, Ms. Castor.
Thank you very much. And I want to stay on this topic. I think you're generally on the right track when it comes to the GME, to say we've got to look at these trends in specialization. I can't tell you how many young residents or med students I meet, med students who are gung-ho, they're going to go into family practice or general practice or pediatrics, and then I see them a few years later and their loans have taken a toll, and they're going to go into plastic surgery or some other specialization. And so I think it's very wise to plan ahead and begin to look at how we create those incentives. So I appreciate that very much. And the diversity mix. MedPAC has done a good job focusing in on kind of the lack of, how the medical field oftentimes does not reflect our population. We need to improve that because that means better care, although women now are going gangbusters in our colleges of medicine. I had really hoped that MedPAC would also address this issue of the static nature of the cap and what that has done to states that have grown in population since 1996 when that cap was put on, because it has created such a harmful dynamic in my state that has been a high-growth state in other areas. We've got three major GME-related issues. One, our resident-to-population ratio is in very bad shape. Two, we don't have nearly enough slots to account for all of our medical school graduates. We have 9 med schools, but at least 2/3 of all students leave the state to practice. And then we have hospitals operating above their caps. They're struggling to pay for those additional residents and fear that they may not be able to keep up with those extra, the extra costs that those slots require. So in the big picture, we can generally say that more slots doesn't necessarily ensure better care or overall better training, as asserted in your report. However, there is this other issue that I know we, in our health care reform law, we said we're going to do a workforce study, and you mentioned that here. And in fact, Secretary Sebelius announced new residency positions just this past week for primary care, so that's very positive. But could you please address why didn't MedPAC consider the geographical inequities here in this report that is so fundamental? It's really underlying the workforce issue and the diversity issue. Can you address that and the impact of cutting the limited GME funds in some states already receive?
We did not make specific recommendations about either increasing the caps or reallocation of them. However, we did suggest that we needed to take steps, Medicare needs to take steps to increase the diversity of the physician workforce of the future and make sure that we're bringing into medicine people who are inclined to practice in rural areas, practice in inner cities that may be underserved. And research shows that an important element in that decision on where to practice is where the student comes from to begin with. And so there are programs in the Public Health Service authorized by this committee that are targeted at trying to change the mix of physicians being trained, increase the diversity. We think those programs that directionally make a lot of sense. Again, on the specific issue of how many positions Medicare ought to support, we didn't look at that issue specifically just for a matter of time and resources, but we do think that it needs to be guided. That decision needs to be guided by careful analysis of future needs, whether they be geographic, diversity, specialty. And the beacon that we aim for is a high-performance delivery system. If we just double the number of physicians with the current specialty mix, we may well not make our problems better. We could end up making them worse. And so we need to think first before we increase the funding.
Yeah, so we've got to harmonize what was in the health care reform law that says the states that have these low resident-to-population ratios are going to get a little bit of help. And I was hoping in your report you would reference that. I know you mentioned in the report that you weren't sure when the law would be finalized, but there needs to be some harmonization of those. And quickly on the IME payments, you know, many hospitals feel that redirecting the IME payments, since the needed level of IME funding is difficult to quantify, leaves them in a position to come up with dollars for indirect costs on their own. And for some states that are looking at dish payments changing over time, and the fact that we may still be serving many folks in this country that show up in the ER but will not be covered by the health care bill, that's very troubling to see another another challenge on the horizon. So if MedPAC recommends that we not make decisions about Medicare funding for new residency positions until an independent analysis of our healthcare workforce is conducted, is it premature to recommend that IME funds be redirected before the study's completed?
I'm going to have to, I'm sorry, Ms. Kasser, I've been not paying enough attention to the time. You're like a minute and 20 minutes.
I'm
so
sorry.
That's all right. Why don't you ask her,
Yeah.
why don't we send that in writing to
Yeah,
you?
thank you,
All right?
Mr. Chairman, because
Sure.
you know I care about that.
I know. I appreciate it. We'll send that in writing. Next is the gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. Mr. Hackbarth, physician reimbursements under Medicare were cut by 21% last Friday. Many physicians in my district have told me they'll stop seeing Medicare seniors because of these cuts. And indeed, some in the more rural areas have said, well, they'll just move to an urban setting where the Medicare case mix is not quite as high. Today, this mitigation, which has passed the Senate, that bill is being delayed by Speaker Pelosi. The bill that would restore these cuts, the cuts that may mean our seniors have a Medicare card but no physician to accept them. Given our current physician shortage and the access problems that Medicare seniors are currently encountering, do you believe that Speaker Pelosi's decision to allow these 21% cuts to go forward will make it harder for new Medicare seniors, especially those in rural areas, to find a physician who'd be willing to take them?
Well, it's obviously not my place to comment on Speaker Pelosi's position, but let me just describe our position on this. Each year we do a large survey of Medicare beneficiaries to ask them about their access to physician services. We survey about 4,000 Medicare beneficiaries each summer. And we survey a like number, roughly 4,000 privately insured patients that are just under the Medicare eligibility age. So we have a reference point. Our survey done last summer, the summer of 2009, found that generally Medicare beneficiaries have access as good as or even better than privately insured patients in the 50 to 64 age group. The area of concern within that generally good picture is around primary care. Part of the survey that we do is we ask Medicare beneficiaries who are looking for a new physician whether they have any problem in finding a new physician. That's the most vulnerable group. And what we find is roughly a quarter of Medicare beneficiaries say they have difficulty finding a new primary care physician. Again, this was 2009. The number for privately insured patients in 2009 was actually a little bit higher. A higher percentage of privately insured patients said they were having difficulty finding a new primary care physician. The lesson that we draw from that is the country has a growing problem with access to primary care. It's not unique to Medicare. It's a broader systemic issue. So that was 2009. We are in the process now of doing our 2010 survey. I don't know what those results will be. I would say, though, that the uncertainty and even anxiety caused by the annual, now more frequently than annual, debate over SGR can only be undermining the confidence of physicians and patients in the Medicare program. And so I don't know what the new survey results will be, but we are concerned that the repeated threat of very large cuts could impede access.
Well, Chairman Hackbarth, I appreciate you bringing that information to the committee, because that's extremely important. And if I understood you correctly, it was, in last year, 2009, before Obamacare, Patient Protection Affordable Care Act, a fourth of Medicare patients seeking new physicians have difficulty finding one. And now we're in a situation where fully 10 million people, Medicare patients on Medicare Advantage, that program's being cut. I think Mr. Shimkus said the number was $130 billion over 10 years. So maybe 6 or 8 million of those 10 million will lose their coverage under Medicare Advantage. And then you compound that problem with a 21% cut. So we haven't put a Band-Aid on it now. And so those many physicians are going to say, I'm out of here. And then you're going to get this deluge of new patients trying to find a doctor to cover them under Medicare. I just hate to think what your numbers are going to show when you survey those 4,000 in June, July of 2010.
I just want to be very clear, because this is such an important issue, about what the 2009 survey results were. So we said that the most problematic area was Medicare beneficiaries looking for a new primary care physician. So that represents about the number of Medicare beneficiaries seeking a new physician is about 6%. And it's a quarter of that 6% that report experiencing a problem. Now, we've got, 45 million Medicare beneficiaries. So, even if we're only talking 1.5% or 2%, we're talking 900,000 Medicare beneficiaries. That's a lot of people in reason for concern. But it does represent like 2% of the Medicare population. And it's also important to emphasize again that this is not unique to Medicare. The privately insured patients were also reporting problems in finding a new primary.
Thank you, Chairman Hackbarth. Thank you for your indulgence, Mr. Chairman. I'm a minute over, and I'll yield back.
Thank you. The gentleman from California, Ms. Eshu.
Thank you again, Mr. Chairman, for having this hearing. Chairman Hackbarth, I have two questions. The first one has to do with the report's inclusion of a proposal that some of the graduate medical education funding provided to hospitals by Medicare be made contingent on practice-based learning to encourage medical residents to spend more time in community health clinic settings. Now, some teaching hospitals in my district and elsewhere don't have the emphasis on outreach with ambulatory care settings right now. What does the Commission think the impact on the current GMA system will be under this proposal, and what is the Commission advising the Congress relative to the transition in order to incorporate what you've discussed in the proposal? And my second question is on self-referral. Experts across the board, of course, agree that physician self-referral, where doctors refer patients for medical services in which they have a financial interest, is a costly drain on the Medicare system. I agree with that. The report goes into quite a bit of detail to demonstrate that self-referral under the Stark's Law ancillary services exemption continues to grow. But noticeably absent from the report are any concrete recommendations about how to address this. So can you address it?
Yeah.
So those are my two questions.
Okay.
Thank you.
Thank you. First on the non-hospital-based training in community practice. A few points there. First of all, that's particularly important for some specialties. Obviously,
yeah, I'm not arguing whether it's important or not,
but
since you make the recommendation about it, and there are many that have brought up GME in their opening statements and some in their questions, my question was, what's the impact and how are you going to, what's the Commission recommending in terms of a transition in order to accomplish this?
Well, the first step is to remove some of the barriers. In the current Medicare rules, there are rules about how the time of residence is counted that impede people from doing non-hospital training.
I see.
The teaching hospitals have asked for those rules to be changed. A number of those changes were included in the Affordable Care Act. And so that's something that the teaching institutions themselves have asked for, to take down one of the barriers. The second step is to make sure that those opportunities for non-hospital training are good experiences, rich experiences. Because that's the experience that primary care physicians, for example, need in particular. That's the environment where they will be practicing. And one of the reasons that young physicians in training don't go into primary care is they have that experience, ambulatory experience, and it's not a good one. It's in a clinic that is not well managed. They don't have time to deal with their patients, and so they're turned off by primary care. Fixing that problem, as you say, is not something that's going to happen overnight, finding new settings, rich settings for people to train in. So we recognize that there will be a period of time. Our recommendation, as I said earlier, is that the new standards wouldn't go into effect for 3 years. But if on this particular issue the Secretary were to decide, even more than 3 years is required to allow ample ramp up, then we wouldn't object to that. But we do think we need to be moving in that direction.
And on the self-referral issue?
Yeah.
Right, the report really does go into quite a bit of detail.
Yeah,
it's really short on your any recommendations.
Well, we lay out, I think, about a half dozen options that might be considered. For example, limiting self-referral to services provided on the same day as the basic visit, packaging certain imaging services, for example, with the visit payment, subjecting some types of high-end expensive imaging to prior authorization. There are, I think, a half dozen different options there. What we've done, each of those has pros and cons, and we've laid them out so that now we can get people outside MedPAC to react to those options, help us deepen our understanding of their implications. And we would expect next year, with that additional information, we'll come back and look at these 6 options or maybe some new ones.
So it's going to take a year for you to gather that information before you make firm recommendations to Congress?
I don't know exactly when we'll take it up in our fall schedule, but it would be in the fall. It wouldn't be next June.
Oh, I see. I thought you said it was going to take a year to get them. That's right.
And next annual cycle is what I'm referring to.
All right. Thank you very much for your work and your testimony.
Thank you, Ms. Eshu. The gentleman from Texas, Mr. Burgess.
Thank you, Chairman. And again, Mr. Hackbarth, we're pleased to have you here. Let me just be sure I heard you correctly when you gave your statement, because we heard some discussion from the dais about Medicare Advantage. And I thought I heard you say that we need a robust Medicare Advantage, and that's something I've heard before at some of the Commonwealth Fund things. We heard that from the head of Scott, or physician from Scott and White last January, who also happened to be the head of the AMA, who endorsed the health care bill, but with the cuts to Medicare Advantage. So why the dichotomy here?
I'm sorry.
Well, we cut Medicare Advantage, and we said that was a good thing in the health care bill, but you're telling us we need Medicare Advantage.
Yeah. Well, if I could, I'd like to refer back to something Mr. Shimkus said. I believe strongly in the market and market signals, and how much you pay for something influences the product that you get. And I believe very strongly that having the option of enrolling in a private plan is a good thing for Medicare beneficiaries. But if we set the price too high, we get private plans that are not properly focused on increasing value for Medicare beneficiaries. We make it too easy. And the evidence that I would cite for that is that when the prices went way up, when we vastly increased the benchmarks on Medicare Advantage, we got a huge influx of private fee-for-service plans, which added very little value.
Well, I do have to interrupt you there, because some of the data we've heard, and we would never got it in this committee because we never had the advantage, but some of the information we've gotten again, from places like the Commonwealth Fund that are not just bastions of conservative thought, that Medicare Advantage did hold the promise. They did the care coordination, the disease management, the ancillary providers, the electronic medical records, all of the things you want your care system of the future to do, they were able to provide. So I heard it at a round table dealing with the Physician Group Practice Demonstration Project that if you don't have Medicare Advantage, we can't do these things that you've asked us to do, and we believe we're on the right track. I'm going to have to leave that in the interest of time. There's some things I just have to ask you. Appendix A of your report suggests that in addition to the 21% cut that went into effect June 1st, there's an additional 6.1% that will be shaved off physician reimbursement based on your calculations. That will kick in January 1st, is that correct? So an aggregate cut from last month of 26% by January 1st. Is there any way to prevent or to create the de-linking? Say that goes into effect. Say there's nothing anyone can do to stop that. Is there any way to de-link private insurance reimbursement from what Medicare is reimbursing? Because as you know, many of the private contracts pay at a percentage of Medicare.
Well, it is often the case, as you say, Mr. Burgess, that private insurers use the Medicare relative value system. But typically, they will use their own conversion factors. So the actual price paid is not Medicare. In some cases, it could be higher. Some cases, it could be lower. Correct.
And in the interest of time, it's generally like 110% of Medicare. But you cut Medicare 26.1%, Blue Cross Blue Shield that pays 110% of Medicare, guess what? They get a big windfall for their stockholders, and the doctors end up holding the bag on that. I do think that's something that I would like to see your group look at. Let me just talk about a couple of things because they're terribly important. In the bill, in the health care bill that passed, we got the creation of the Independent Payment Advisory Board. Will that render the sustainable growth rate formula obsolete, or are physicians perhaps facing the specter of both the SGR and cuts in the Independent Payment Advisory Board?
Well, my understanding of the legislation is that the targets established for the Independent Payment Advisory Board are separate from SGR.
So the answer is yes, they could be hit
Right.
with both.
Right, and the difference, of course, is that the independent payment targets are program-wide. They're not just focused on physician.
Right, but again, that is one of the things that I think needs to be looked at with a great deal more scrutiny because I'm getting these questions, and I got to believe that doctors who are looking down the road at what have we done to them are going to be taking this quite seriously. And you may find your numbers of people who can find a Medicare physician actually dropping off more significantly than you anticipated. The last thing, and the chairman has such a quick gavel, on you brought up on the prior authorization on imaging. Why is it, and I hated prior authorization. I hated calling 1-800-California to get a procedure approved. But why doesn't Medicare look at a little bit of that type of activity? It's always the pay and chase. You pay something and then wonder if it was advisable to do so and then try to chase someone down. In the private world, you end up having to get everything pre-authorized, which is a pain and sometimes overdone. But why not incorporate some of the lessons that have been learned in the private sector to hold down the cost in Medicare?
Right. That's got to be the last question. Go ahead.
See, I told you he's quick with that.
Yeah.
Go ahead.
As you know, increasingly, prior authorization is used for expensive imaging services. There are companies that specialize in that business running those prior authorization programs. And it's an option that we will look at. Obviously, the concern is the intrusiveness of it, the hassle of it for physicians, but it also has some advantages. So I don't know where we'll come down, but we will look at it.
Ms. Christensen?
Thank you, Mr. Chairman. And again, thank you for being here, Dr. Hackbarth. I had to step out when my colleague, Dr. Burgess, was speaking, but I think I just have to get this off my chest because I really think that MedPAC has the whole provider reimbursement issue backwards, and therefore the remedies are not really directed as they should. And I just wonder if MedPAC has ever considered that providers are paid so very low reimbursements that they just have to see more patients to be able to keep their lights on, pay their staff, keep their doors open, as well as take care of their families. All of the remedies are seem to be based on the assessment that fee-for-service is a source of the problem, but I really think that it's the low fees. Doctors are really forced into a position where they have to see more patients, and CMS has never really paid us to sit down and talk or listen to our patients. So I just wanted to get that off my chest.
Well, in fact, we would agree that there are some physicians who are paid too little. Being paid fee-for-service may not even be the best method for paying a primary care physician. But on the other hand, we think that there are other physicians who may be paid too much. And so rather than saying, oh, we think all fees should be cut, our view is more nuanced. We think that there's plenty of money in the Medicare physician payment pool in the aggregate, but it needs to be redistributed to support high-value care. I mean, more for some, less for others.
But does that mean, and I, as a primary care physician, I appreciate the fact that primary care is going to be given more attention and have perhaps some higher reimbursements, but I don't see that should be at the expense of the specialists. When you need a specialist, the situation is generally critical, and they have a specialized, by definition, service to provide.
Well, before I started doing this job, I was CEO of a 500-physician multi-specialty group practice in Boston. And our physicians were all paid on the salary. We were largely, at that point, prepaid group practice. But if you look at the difference between a primary care physician and a cardiologist or some specialist within a group like mine, or you do the same at Kaiser Permanente today, the range is much narrower than exists in fee-for-service. Yes, the specialists get paid more, but it isn't the huge gap that exists in fee-for-service Medicare. And so what we're suggesting is not that specialists not be paid appropriately for their additional training and the like, but we do think that gap needs to be smaller.
Thank you. Let me try to get one other question, and my time is fast escaping. When CMS institutes a least costly alternative policy or code bundling determination, providers face a financial loss each time they prescribe a product that is not the least costly product, subject to the LCA policy, or a product that is more costly than the blended reimbursement rate under a code bundling decision. To the extent that Congress grants CMS explicit authority to institute LCA policies or expanded code bundling authority for drugs or biologics, what safeguards does MedPAC recommend, including in such authorities, to ensure that patient access to important therapies is appropriately preserved? And what kind of clinical evidence should CMS be required to consider before instituting that policy or bundling determination? And what exceptions should Congress include to make sure that patients can get Medicare coverage for the more costly products when they're medically necessary?
Yeah. Well, the decisions in executing least costly alternative reference pricing options of that nature need to be informed by the best available clinical evidence. And the process needs to be a transparent one whereby all interested parties have an opportunity to present their information to CMS. As we say in the report, we think in some areas like this, it would be good to give CMS and the Secretary more flexibility than they have under current law to execute these policies. But that doesn't necessarily mean abdication by the Congress either. You could imagine ways that the Congress would reserve the right to override particular policies and the like. So we'd like to see the needle shifted some towards more discretion, but only based on evidence, transparency, and there could be some residual congressional control.
Okay, I think my time is, I'm over my time. Thank you.
Thank you. A gentleman from Kentucky, Mr. Whitfield, who has 8 minutes.
Thank you, Mr. Chairman, and Mr. Hackbar, thanks very much for being with us today. We appreciate your presence. I want to revisit this one issue that Dr. Burgess mentioned, and that's Medicare Advantage. Mm-hmm. And I want to do so because there are 13,000 seniors on Medicare Advantage in my congressional district. And my understanding is that there will be $200 billion taken out of the Medicare Advantage program. And in your testimony, you talked about the need for a robust Medicare Advantage program. And it seems to me that taking $200 billion away is the exact opposite thing that we would need to do in order to have a robust Medicare Advantage program. And I would just like your comments on that. And I have not had the opportunity to read all of this report, but what do you say about that in this report, if anything?
Yeah. For many years now, going back to 2001, MedPAC had recommended reducing the Medicare Advantage rates. We've believed that reducing them would still leave ample resources for a well-run, high-value Medicare Advantage plan to do very well in serving the Medicare population. I've been a senior executive in such a plan. I've run a medical group that had a lot of Medicare. It was back then Medicare Plus Choice. This was pre-Medicare Advantage. But I know a little bit about such programs from the delivery side. Just increasing the rates, as was done in a series of steps by the Congress, does not assure a robust Medicare Advantage plan. In fact, in crucial ways, it undermines it. By allowing signaling to plans, you can do very well while doing very little. And again, the evidence that was occurring is as the rates got very, very high relative to fee-for-service Medicare, we had a large influx of private fee-for-service plans that were adding very little, if any, value to the Medicare program, but doing very well. That was not in the interest of the Medicare Advantage program, to allow low-value performers to do very well. If you reduce the rates, yes, you make it more difficult in the first instance, but it's also the spur to finding ways to do things better that is needed. That's what drives markets. It's that spur, that pressure to find new innovative ways to produce a high-value product. That had gone out of the Medicare Advantage program due to overpayment. And so there is a lot of waste in traditional Medicare. You know, we fill books each year documenting the waste in traditional Medicare. An innovative private plan, well-managed and really focused, can find ways to provide Medicare benefits plus more to the Medicare population for less money than fee-for-service Medicare. I believe that.
Okay, so so it is your position that you can maintain a strong, viable Medicare Advantage program even though you take that much money out of it?
Initially, you are likely to see a reduction in the number of plans and a reduction in benefits, higher premiums, fewer enrollees. That's the short term. The long term, though, is it will begin to change the nature of the plans that participate, and I believe towards a higher value, more worthwhile option for Medicare beneficiaries.
And over the long term, would you guess that there would be more Medicare Advantage programs available?
More individual plans offered. Again, it's going to depend on what your time horizon is. In the first couple years, I would expect that you'll see fewer. The easy money is gone, and people will say, "Oh, the easy money's gone. I'm going on to something else."
Right.
But over time, I think that you could see those numbers start to increase again.
Also, I noticed on page 3 of the report in Chapter 1, and I told you I hadn't read it, but I read the first page already. But it says in this report that you describe the least costly alternative policy as one way that CMS can apply the results of comparative effectiveness research in order to help contain Medicare spending. And yet, when we were having the debate on the health care reform legislation, many people, including the President, were stating in no uncertain terms that comparative effectiveness research is providing patients and doctors with the information they need to make the best medical decisions. And there was never any reference to being a mechanism for cutting cost. So this report basically does say that that's one of the purposes of it. In your mind, is there any inconsistency there that on?
Well, I won't try to represent what President Obama or anybody else said. Let me just say what I believe. I believe that it's in the interest of patients and physicians and the broader population to have more information about what works. That information, as it's developed, can be applied in many different ways. One would be to inform policies like least costly alternative. Another would be to build into shared decision-making programs where Medicare beneficiaries and other patients can be more actively engaged in making choices over their own health care. Still another way might be to identify potential areas to reward through pay-for-performance programs. There are still another way might be to inform coverage decisions. There are a lot of different ways to use that information. You add them all together, having better information is good for patients and good for physicians.
Thank you, Mr. Chairman.
Thank you.
May I yield him 30 seconds?
Mr. Hackworth, I just one follow-up question on the Medicare Advantage. You referenced Medicare Plus Choice far before my time here, but that kind of went away because it was underfunded, did it not?
The enrollment did increase. We went through a similar cycle.
The short answer to the question is yes. Let me ask you something else before the small amount of time I have goes away. Wouldn't it have been better if we stipulate that you are accurate about your statements of Medicare Advantage and there's more money going into Medicare Advantage than needs to go into it, and if we have these additional dollars in Medicare, wouldn't it have been better use of those funds to keep them in Medicare and deal with the number one problem that's going to affect access for Medicare patients in the future, and that's offsetting the cost of fixing the SGR formula?
How to allocate funds is really above my pay grade. Those are choices for the Congress.
We've got a whole book here about allocating funds.
All right, we got to move on here. Next is Mr. Barrow. Okay, Mr. Green.
Thank you, Mr. Chairman. I heard there were questions earlier on graduate medical education, or in Congress we call it GME. And because I want to make a point on it, I was a sponsor of the provision in the health care bill that on residency training in our FQHCs, because we have a great example in the Houston area of the Denver Harbor Clinic with an agreement with Baylor College of Medicine. Greater accountability in GME isn't a bad idea, though, and we need to debate exactly how we're going to go about doing that, because we don't want to hurt our hospitals or our resident programs, but we also like to make sure those physicians, those medical students know they can make a good living by practicing in FQHCs, and hopefully we'll grow them. Mr. Hackworth, I want to thank you, like all the committee members, for you being here today and the report. Your testimony and the report discussed demonstration projects at CMS and certain hurdles that these projects face, including low levels of funds and constraints on CMS in conducting these demo projects. Can you discuss these issues? And I know many of us in Congress, I like having CMS conduct a demonstration before implementing a broad policy on everyone, simply because it's a test model to see how it works and if it's successful. Could you just address that?
Yeah. Well, as you well know, Mr. Green, the health reform law took a major step in terms of increasing funding in giving the Secretary a broader authority in doing testing new ideas for Medicare. And we think that's a significant step in the right direction. In order to meet the challenges that Medicare faces, of slowing the rate of increase in costs while preserving or even increasing the quality of care, we're going to need to change how Medicare pays for services. And the problem that we've had historically is that process for testing new ideas is painfully slow. From conception to completion, we're often talking 7, 8, 9, 10 years. At that rate, we will never get the job done. The steps taken in the Affordable Care Act, we think, have the potential to accelerate that process somewhat. We think that's very important. I would add, however, one of my biggest concerns is that let's assume, as I think we all hope, that we can run some successful demonstrations and develop new ideas that work. Those ideas need to then be operationalized by CMS. And I worry that even though we've given more funding for the research and demonstrations, we are still chronically underfunding CMS operations. And if we continue in that pattern, we can have all the great ideas in the world. They won't get implemented, or they'll get implemented poorly, and we won't be any better off than we are today.
Okay. Well, that brings up the next question. You also mentioned the newly created Center for Medicare Innovation, which was authorized under the health reform law. Mr. Whitfield and I have been working on a demonstration project we think that meets the criteria for a CMI demo, and the health reform law provides CMI with $10 billion in funding to carry out these new demonstration projects, which in my opinion is a sizable amount of money. May not be enough, because hopefully we will see lots of ideas that can more effective and even more reasonable cost delivery of medicine. Yet your testimony indicates that there may not be enough funding for CMS to carry out all the demo projects, even though none have been taken up yet, because frankly it's only been the law a very short time. And that what are the issues that may cause CMS, even though none of that has been taken up, this may cause issues within CMS with the fee-for-service model. Can you discuss your statements on the Center for Medicare Innovation of the CMI?
Well, I would agree, Mr. Green. The $10 billion funding is substantial, a huge increase compared to what CMS has had historically for this activity. And so I don't mean to be critical of that at all. I think it's a big step forward. I do think it's important for Congress to be sensitive to the complex task that CMS now faces. There are a lot of potential candidates for new projects. And these new projects are still going to take time to set up, operationalize, get running. And then it's going to take time to get results. So even with $10 billion, this isn't going to happen with a snap of a finger. And then there is, as I said a minute ago, still the issue about let's assume the best case that we have successful demos. We still need resources in CMS to operationalize. So it's a good step, but we need to be realistic. We've got problems still to solve.
Yeah. Mr. Chairman, I have other questions. I know I'll run out of time even without giving an opening statement. So if we could submit questions later and get responses back. My next question, in your report you state about half of the imaging studies are performed the same day in the office visit. You state that this is a reason to reevaluate the in-office ancillary exemption, and I assume because you feel that is a low number. However, this number of 50% seems to be that quite a few evaluations of patients' conditions were helped by being able to quickly diagnose an issue by performing an imaging study in the office. And I'd imagine that clinically valid reasons when a physician may not want a patient to may want a patient to rest or then revisit if the condition doesn't improve would lead to imaging study done on a different day. If half are performed on the same day, it would appear that we're meeting the test for the need for the self-referral exemption of timeliness, convenience, and coordinate care that same-day diagnosis allows for. Do you feel that this is a low number, the 50%, or is it unrealistic to expect that this could be considerably higher?
Well, so what we were trying to do is provide some data on what was one of the original reasons for having an in-office ancillary exception to the self-referral law, and that was to allow same-day treatment and imaging. And so what we did was look at, in fact, whether that's the case. And what we found was that for some services covered under the exception, therapy services, it was rarely the case that they were provided the same day. For advanced imaging, MRI, CT, and the like, it was provided same day less frequently than half the visits. And then for the standard imaging, standard X-ray and the like, that was about half the time. Okay. And so there's variability depending on the particular service. But I would emphasize that this is an area where we need to tread carefully. There are some legitimate rationales for allowing physicians to do these services, including potentially accelerating diagnosis and treatment, making sure that the patients get the needed tests and the like. In other contexts, we sing the praises of integrated practice. Yeah. And so it's not so much the integration that's a bad thing. It's not so much the physician ownership that's the bad thing. It's the combination of physician ownership with fee-for-service and often mispriced services. It's that combination that can be toxic and lead to overutilization of services. And so we're trying to figure out ways to solve the problem without throwing the baby out with the bathwater.
Well, because I understand you have an endocrinologist, its ability to give a bone density test literally in the office there. It saves the time for another office visit for them to go get a test somewhere else. Mr. Chairman, I know I've run out of time, and I'd like to submit the remaining questions. Thank you.
And I'll mention that any member can submit questions in writing, and we'll ask you to get back to us as soon as you can. A gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Thank you, Mr. Hackbarth, for being here. You spent a chapter of the report discussing shared decision-making and its implications in Medicare. And I found it interesting that there was no explicit discussion of shared decision-making around care provided at the end of life. And especially given my sense that there's a fairly profound amount of end-of-life care that is provided that is not necessarily aligned with a patient's wishes or values. I wonder if this omission is because you see these issues as being distinct, or in fact, could you share with us your thoughts on shared decision-making between physician and patients to improve care at the end of life?
Yeah. So what we did in the chapter is our staff went out and looked at some of the existing programs for shared decision-making. It wasn't the whole universe of programs or a representative sample. We went to a number of them. In the programs that we looked at, they did not tend to be focused on end-of-life issues. They tended to be more focused on treatment for breast cancer or prostate cancer, some of those examples. The potentially rich opportunity for shared decision-making is in what some people have called preference-sensitive care, where the right care is not something the physician can decide. It depends on how the patient assesses various risks, benefits, different potential outcomes. And so shared decision-making is a way of helping the patient express their preferences. Given that is, the underlying logic, it would seem that it could be applied to end-of-life issues. But as we looked at the programs that we described in the report, that was not their principal focus.
Okay. In the report, I commend you for spending as much time and energy as you did looking at models to serve dual eligibles beneficiaries. These are folks who suffer not only from debilitating health conditions, but also from a system that leaves them with often poorly coordinated care. Now, in your report, you mention special needs plans, and specifically you profile a successful program that we have in my home state of Wisconsin. Yet there's also notation that these programs vary significantly across the country. So I'm wondering if it's your expectation that the new requirements that special needs plans establish state contracts will improve the quality and consistency. And then I have a follow-up question about the National Committee for Quality Assurance and their role in this.
Yes. A couple years ago, I'm not going to be able to remember the exact date, we did a chapter focused on SNPs, on the special needs plans, and made a series of recommendations there. And one was that for the plans focused on the dual eligibles, that it was very important for there to be a contract with the state that specifies a lot of important operational details. And so we think that the requirement in the Affordable Care Act that there be contracts is a step in the right direction. Now, not just any old contract will do. It's important that the content be right, to be sufficiently detailed and the like. But we do think that's a step in the proper direction.
Then you focus, again in this chapter, on the importance of measuring outcomes. Yet I think we lack information both on the best quality measures and the actual outcome data from the plans. So I understand that the National Committee for Quality Assurance is developing some additional reporting, but whose responsibility should it be to collect and analyze this data? Does there need to be congressional action to require this, or is it already within the powers of the agency and part of their obligation under the law?
Well, let me just begin first with full disclosure. Until very recently, a month or 6 weeks ago, I was a board member at NCQA. So I just wanted to put that in the record. In terms of who does the actual development of the standards and measuring of performance, typically in an NCQA accreditation program, they're specifying the data required and evaluating the performance against that data, and then CMS basically piggybacks on that. And so I would think that's the way the process is working. Am I misunderstanding your question?
Well, I'm just wondering whether there needs to be additional congressional authority at this point in time. Is it already within the powers of the agency and part of their obligation under law to do this analysis?
Well, rather than risk erroneous answer, could I respond to that request in writing?
Absolutely, and since I've already expired my available time, that would probably be preferred by all. So thank you.
Thanks.
Thank you. The gentleman from New York, Mr. Weiner.
Dr. Harpeth, thank you for being here. I think that there is broad agreement that we need some kind of a model to go take a hard look at Medicare, try to figure out ways to save money. But when there was a proposal to expand MedPAC, a lot of us during the deliberation on the health care reform were very much against it, because this general sense that there's a bias against big cities, there's a bias against graduate medical education. And unfortunately, the most recent report kind of reinforces a certain tone deafness on some of this stuff. And I think that the report does some remarkable things, but when it talks about a $3.5 billion cut to IME funding in the exact same document where it points out that many teaching hospitals have negative margins presently, and further ignores the idea that we're in this movement, as you've testified to, of trying to move away from more and more people going into emergency rooms and more seeing primary care physicians. It just seems to me that it's wildly counterintuitive, and it's not a question, but I'd be glad to hear your response.
Yeah. First of all, I just want to be clear that we are not recommending a $3.5 billion cut. What we are recommending is that at a point in the future, at least 3 years in the future, that teaching institutions be held accountable for their performance. and that money, that $3.5 billion, be contingent on performance. The 3-year period would be used to engage both the teaching hospitals, people in academic medicine, patient representatives, purchasers, healthcare delivery organization in the development of those standards. Our fondest hope is that every cent of the $3.5 billion would be paid out, because that would mean that good standards have been developed and the programs are performing well against those standards.
So on page 102, recommendation 4-1 does not suggest the cost savings.
Our goal, as I said, our hope would be there would be no reduction in Medicare expenditures.
I see.
That would signify that the programs are achieving the job. They're being accountable for the performance.
Right. Let me spend a moment on self-referral. You identified, I mean, there are various numbers in the report, but it's something like 104% overpayments, we think, for self-referral. And there was some consideration in the consideration of the health care reform bill, again, to basically ban wide swaths of the self-referral, include them under the Stark. You know, you've shown that in your report that an overwhelming number, the costs go up overwhelmingly for second and third day referrals. Can you tell us, is there any reason we should still permit physicians who clearly are conflicted from doing radiology, from doing an MRI, from doing these various things? I mean, the evidence seems so clear that it's not that doctors are being venal, but they've got this giant machine sitting in their office. They've got to make payments on it. It just seems like too great a temptation. Isn't there a much more bright line recommendation we can make here to simply say, just don't permit those self-referrals anymore? I mean, this is no longer the type of thing where maybe you say only if it has to be in an emergency where someone walks in with a sprained ankle, you want to do an x-ray, which, by the way, is, as you know, the reason any exemption existed in the first place. I mean, I think, you know, I mean, it just seems to me that we're past points of dancing around this, and I think that type of prohibition is in order.
Well, as I was saying earlier, before I took this job, I was the CEO of a very large physician practice in Boston. 500 physicians, all sorts of different...
Your career is not taking the best projectile so far, but...
we all make choices. My group, brought high-end imaging, MRI, CT, in-house. We thought that it improved our ability to effectively manage the care, coordinate the care, assure the quality of the imaging, and the like. A lot of notions of where the healthcare system needs to go in the future is towards more integration, not having all these separate independent providers, but more organized systems. If we want to move in that direction, we don't want to discourage ownership. The problem isn't the ownership per se, it's the combination of ownership with fee-for-service payment and mispricing of services, so there's easy profit opportunities. That's the toxic combination. It's not one, it's the three of them together. And so what we're trying to do is identify options that allow us to preserve the good part of integration while doing away with the bad part.
Well, I have to say in my remaining, actually my time has expired, but let me just say that, you know, if we're going to get if we're going to get your organization to a place that we really see it as a tool to start to do more of these savings and reinforce some of the good work you do in the report, you do have this institutional, you sense it here, this institutional sense, and Mr. Pallone talked about it during the debate on health care reform, this institutional sense that you don't get it when it comes to teaching hospitals. But more than a few members have mentioned that. But I yield back the balance of my time.
Thank you, Mr. Wiener. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman. And thank you for your testimony today. I come from a very rural area of Ohio. It's a large district in southeastern Ohio, exclusively rural. The largest town we have is about 27,000 people. And we have historically suffered from a inadequacy of physician workforce. And I think that's something that's probably true for most rural areas around the country, especially those that are relatively indigent or poor. Can you talk about why this deficit is problematic in the context of its impact on creating a rural workforce?
Mr. Space, which deficit are you referring to?
The deficit pertaining to access primarily to not just family physicians, but physicians generally. We have a difficult time recruiting subspecialists. Okay. We have a very difficult time recruiting primary care physicians. And I'm curious as to your thoughts as to how that impacts creating the rural workforce.
Well, clearly, recruiting physicians is essential to provide quality care, and there certainly are documented problems in recruiting physicians in particular to rural areas, but also some inner city areas as well. In a report, in the chapter on graduate medical education, we note that there are a number of programs authorized through this committee in the Public Health Service that are focused in particular on recruiting people into medicine that come from rural areas or inner cities or are drawn for certain minorities or ethnic groups. And although the research literature on the effect of those programs is not as robust as we'd like to see it, that makes a lot of sense to us because there is pretty good research that a physician who comes from a rural area is more likely to go back there.
And I think you could probably add to that, and maybe you have research that would corroborate this, but a physician who trains in a rural area is more likely to stay there. In fact, I think I read that in your report. While we're on this subject, on page 117, figure 4-1 of the report, there's a graph that kind of outlines, I guess, third-year internal medical residents becoming subspecialists or hospitalists, and it's actually quite remarkable. From 1998, we saw a predominance of general internal medicine, somewhere in the neighborhood of 54%. That has shrunk to a 2007 level of, it looks like, around 25%, while subspecialties and hospitalists have experienced a marked increase. I have a kind of a sub-question about that phenomenon.
Yeah.
And I think your report quite correctly points out that we need to do something about that.
We do.
Now, it seems to me that, in the end, it's about money. It's about compensation or the lack thereof that drives folks into those fields. And I think the same thing would apply to family medicine, family physicians, primary care. Short of increasing the compensation for, in this case, general internal medicine practitioners, or decreasing the compensation paid to subspecialists or hospitalists, what avenues are available for Congress to rectify what is a growing and increasingly large discrepancy for those who are training to become physicians?
Well, actually, one of our commissioners, Dr. Karen Borman, has published on this topic of why physicians choose various specialties. She's a program director in general surgery. And money is certainly one of the factors, but it isn't the only factor. Another important factor, in some cases even more important than money, is lifestyle. And do they envision living this job? And often that's a drawback about primary care. Physicians in training, they experience primary care while in training in an ambulatory clinic that has way too many patients, way too few resources, and they say this lifestyle is just not for me. This job is not doable. So we do think that increasing payments for primary care relative to subspecialty care is a step in the right direction, but it may also be necessary to change how we pay for primary care. And as you know, that's part of the idea behind the medical home. let's, in addition to paying fee-for-service, pay per-patient amounts that allow a primary care physician to build some infrastructure, hire some staff, to make the job more doable. So even if that money is not take-home pay, if it allows them to have a more robust practice, it can make primary care a lot more appealing. And then there is the recruitment issues. Again, if you recruit people from rural areas into medical school and train them in rural areas, they're much more likely to do family practice in your part of Ohio than somebody who's trained in New York City.
Yeah, are there tools available for the medical schools or even at the college level, where I assume some of this recruitment is happening, that would channel people early to take an interest in and begin pursuing a career in primary care, rather than waiting until they're out of medical school and then throwing them into the GME program, where they might be more inclined to focus on financial issues?
Yeah. There are a number of programs in the Public Health Service that are designed to intervene earlier in the decision-making process and recruit people into medicine from diverse populations, and then encourage careers in primary care. Because they're outside of Medicare, frankly, I don't consider myself a real expert in all the details. But generally speaking, we think that sort of earlier intervention effort holds a lot of promise, and would urge a careful evaluation of those programs, the PHS, to see how we can build on them and make them as effective as possible.
Okay. Thank you very much. I yield back balance of my time.
Thank you. We have about, 7 or 8 minutes left, so we're going to conclude with Mr. Engel. When I say that, I mean their votes. I don't know if the members realize we have 3 votes.
Well, thank you. Thank you, Mr. Chairman. I won't take the 7 or 8 minutes. I just want to pile on Mr. Hackbarth because about the IME, the indirect medical education. It's a major concern to my area, New York City, and I echo everything that Mr. Weiner said. We are very, very concerned. There are many, many teaching hospitals in New York City. They've been devastated by cuts on the federal and state level, whether it's dish payments or in the health care bill that we passed. We had a whole fight over do-gooder states provisions and things like that, and they've just been decimated back and forth. And New York has 15% of teaching hospitals. We train 15% of the doctors across the country. So this is a really big thing for us. And I know you said that it wasn't a $3.5 billion cut per se, and that that cut supposedly would fund a new incentive grant program under which these teaching hospitals would still receive funding if they show their furthering goals, but they're yet to be established goals by the Secretary of HHS, and the New York City teaching hospitals are very worried that they would lose up to $450 million annually, and that just is really untenable. And so I really I understand that, but that what you just said before about you want to make sure there's quality. Of course, we want to make sure there's quality, but at some point, you can't get blood from a stone, and I think that these hospitals are just about at that point, and they're some of the best hospitals in the country. And every time we look for money, or every time we look to so-called reform something, we hit them again and again and again. And at some point, it obviously is going to affect the quality of care, or what they can provide, or how many nurses they can hire, or things like that. So I just want to echo what so many of my colleagues have said, and I really wish you would, look again at that point, because our teaching hospitals just, cannot afford even the whisper of cuts. It can have a very negative and debilitating thing that could happen to them.
Well, I certainly understand the anxiety about it, Mr. Engel. But that uncertainty often accompanies needed change. I don't think that in any sense whatsoever we are anti-teaching hospital, as Mr. Weiner suggested. The vote on this recommendation was unanimous. Two of the members of the commission are deeply involved in medical education and graduate medical education training. I've referred a couple times now to my group in Boston. It's Harvard Vanguard Medical Associates. Our principal hospitals were the Brigham and Women's Hospital and Children's Hospital. I have no antipathy whatsoever towards teaching institutions. But we do think that the taxpayers, the healthcare system, the Medicare beneficiaries deserve some accountability in the use of the resources put into GME.
But you see, I'm not going to argue with that statement, but I question whether the way you propose to go about it is the best way in going about it. You know, obviously we need to train tomorrow's doctors to have the appropriate skills to provide care in a modern healthcare system, but I just think slashing funds to teaching hospitals with no guarantee that they'll be recouped, I don't think that's the best way to prepare future physicians. I think it causes a lot of angst, and I think it's negative. And you know, the reports that we have, I think that MedPAC reports that teaching hospitals now have negative Medicare margins, which obviously means Medicare is not covering the cost of caring for Medicare patients. You know, what could be the justification of even a whiff of cutting funding to teaching hospitals so that Medicare pays even less? It makes no sense to me.
Yeah. I certainly do understand your perspective on it, and take it really seriously. I do. At the same time, I hear from a lot of colleagues involved in academic medicine who believe the system needs to be reformed, believe that teaching hospitals can do a better job of training physicians for the future, that Medicare is their last hope. There's too much inertia in the system. There's too many people do real well with the status quo. They need a catalyst for change. They need somebody to boost the prospects for reform in medical education. And these are people engaged in the system and say, we need Medicare to be the lever that moves the system off the dime.
We're out of time because
Okay,
we're going to miss
Mr.
votes.
Chairman.
I apologize, but we think we only have a minute and a half before we finish votes on the floor. So let me thank Mr. Engel and thank you also. As you heard, many members want to submit written questions. We ask them to submit them within 10 days and then have you respond to them as quickly as you can. But thank you so much for all that you do. And without objection, the meeting of the subcommittee is adjourned.
Sorry about going in.